Mr. Chairman, thank you very much. And I would like to thank the organizers as well for inviting me here. So my golden 15-minute start now. And these are my disclosures. I should probably also mention that I was the senior investigator of the TTM trial, which makes me a little biased, as you will see in my presentation. So the chain of survival. Yes, my personal thought is that the largest potential for improved outcome is in the early phases. And we have gone through some of these issues in the previous talks. However, I will talk about the post-resuscitation care that in many centers today has really become much better than previously. So how to improve further the post-resuscitation care? Well, in general, we should offer good ICU care. We should use SOPs, or standard operating procedures. We need to focus on resuscitation of the heart and also resuscitation of the brain. I will not talk about those two issues in my presentation. I will instead focus on how we can monitor neurological recovery, performing careful prognostication. That is probably very important, to use strict rules for withdrawal of life-sustaining therapy. And in practice, that means that we need to prolong care. We need to follow up all survivors post-hospital discharge. This is not how it's done even today in many hospitals and countries. We also need to assess the needs of close relatives, and we should offer rehabilitation of those patients in need. This is a timeline of post-resuscitation care, and you see cardiac arrest, you see normothermia on the timeline, weaning of sedation, and in those who do not wake up at 72 hours, we initiate prognostication of patients in coma. We do apply TTM at 36 for 24 hours in our unit, and we do avoid fever up until 72 hours after the arrest. In selected patients, we do the early assessment and search for cause of arrest. And in all patients, we do the repeated neurological assessments. We do use continuous simplified EEG in all patients now for 12 years. We also follow the biomarker NSE that we are very fond of. So the later assessments do focus on neurological recovery. And how do we then monitor neurological recovery? Well, we do use several different methods. We use neurophysiology, we do use biomarkers, clinical examinations and repeated clinical examinations, which probably are the most important tools we have, and also imaging. This is one algorithm, one scheme that we published some time ago. It was later developed somewhat, but after the cardiac arrest, we had the intervention, we had the rewarming, and at this time, when we wean sedation, we pretty much have three types of patients that we see at that time. We do have the patients who wake up early and have a good outcome. I mean, we don't need to do any fancy things with these patients. They wake up, they have signs of recovery, just let them be, they will have a good recovery. We also have a group of patients with early myoclonus, early status myoclonus, and with a poor outcome. We could perform an early SSCP, for example, in these patients, and actually stop active care at some time. Then we have the large group with delayed recovery, indeterminate recovery, where we should really do what we can to prognosticate carefully, to offer these patients good care, to offer them a possibility to recover. We need to prolong care in these patients, and before we withdraw, we must be very sure that we do the right thing. This algorithm I showed was then developed into the algorithm that is that is recommended by the ERC and the European Society of Intensive Care Medicine guidelines in 2015. And again, cardiac arrest, intervention, rewarming. And in order to qualify for this algorithm, you have to wait 72 hours or longer after cardiac arrest, and you have to be in a Glasgow motor score 2 or worse in order to enter the algorithm. And if you are, at this time, if you have no pupillary and corneal reflexes, or if you have bilaterally absent N20 potentials, poor outcome is very likely, as you see to the right. If this is not the case, you will have to wait another 24 hours, and at that time, if 2 or more of the following are present: status myoclonus that was initiated, that started early. If you do have high NSE levels, and we do not specify these for special reasons, I will come back to that. If you have a highly malignant EEG or a diffuse anoxic injury on brain CT, if you have 2 or more of these, poor outcome is likely and you may withdraw care. But importantly, if you're unsure, if you're not sure, and if these are not fulfilled, you need to prolong care longer and 24 hours at a time. I think these are still valid, and I think we use them actively in our unit, and I do recommend to use them. So with regards to prognostication, I would like to show you some data about the reliability of clinical findings in the TTM trial. This is one paper published rather recently in Resuscitation. First author, Irina Dragancia, a neurologist in Lund. And what we found here with data from the TTM trial was that the bilaterally absent pupillary reflexes, the bilaterally absent corneal reflexes, and the absent SSCP N20 peaks were still reliable markers of a poor outcome, with a false positive ratio of less or less than 2%, while a GCS motor score was not reliable, GCS motor score of 2 or less. And importantly, reliability was not altered by temperature, 33 or 36. With regards to biomarkers, these are our NSE results. Now, remember, we collected blood in a biobank. We brought them to Luxembourg. We did a batch analysis of all samples at a time. So we reduced a lot of bias. These results are really quite nice, and probably better than you would if you just collected samples at random from different sites, because results do differ between laboratories, between hospitals. But when you do it in one site at one time, batch analyze, this is what we get. To the left here, you see serial samples at 24, 48, and 72 hours after cardiac arrest. And you see that the good and the poor outcome, good outcome levels and poor outcome levels at 24, good outcome and poor outcome levels at 48, and so on, they nicely separate. And you also see that the levels at 33 and 36, they are almost identical, so no difference between temperatures. And the ROC curve looks rather nice, and the areas under the ROC curve were in the joint sample 0.85, which makes NSE a robust and clinically useful outcome predictor under these circumstances. What about EEG findings in the TTM trial? Well, we do have some interesting data here recently published. We did collect routine EEGs in all patients 48 to 72 hours after cardiac arrest if they were not awake. And this is Erik Westphal in the picture, and what we did, we collected these routine EEGs, and for this specific study, we chose 8 sites and 202 patients, 103 EEGs were investigated. We used the American Clinical Neurophysiology Society's critical care EEG terminology, and we had 4 EEG specialists from these 4 countries interpret these 103 EEGs independently and blinded to outcome. And we asked them to strictly define the highly malignant patterns they found, the malignant patterns and the benign patterns based on this terminology. We also looked at the inter-rater variability between the 4 neurophysiologists. So when it comes to the highly malignant EEGs, I will come back to what those are. The strength of the inter-rater agreement was substantial, with a kappa value of 0.71. So that was a good result. These are the highly malignant EEG patterns. The suppressed background with continuous periodic discharges, burst suppression with more than 50% of the measurements being suppressed, and the burst suppression with superimposed discharges. Now, we did ask the neurophysiologist, what is the ability of these highly malignant patterns to predict poor outcome? And these are the results, and this is quite interesting. We found the highly malignant patterns to have a specificity for poor outcome of 100%, with a sensitivity that is actually better than for SEP or for biomarkers or for any other method that I'm aware of. It was 50% in this cohort of patients. So finally, a few words about follow-up of survivors. And in the photo here, you see Gisela Lilja, an excellent person. She's an occupational therapist. She recently defended her thesis. And I will not go through this flow chart. I will not have time. I would have liked to do it. But this is the flow chart that we actually used for follow-up of cardiac arrest survivors in Lund before the TTM trial. We used it pretty much in the TTM trial, and we still use it after the TTM trial. To make a more easy scheme, this is pretty much how we do it. After discharge, we do screen all patients. We have them come to an aftercare nurse in the ICU at 2 months, approximately 2 months after the arrest. At this time, all patients get information, and we do ask the patients to bring their close relatives too, their next of kin. They get information, they get a telephone number, they can call back, they may contact the aftercare nurse. In almost 40 to 50% of all patients, they are being referred for assessment by an occupational therapist. And this takes part. This is done 4 to 6 months after the arrest. And here they get again information, and after this assessment, some patients are referred to a neurologist or to rehabilitation medicine. Now this is not the whole picture, because some patients are referred to rehabilitation medicine at discharge. But this is just a scheme that we use. This is how we do it in our region of southern Sweden. So rehabilitation of those in need is also an area where a lot of things happen now. I will not go through much detail about this, but I will take the chance to market our meeting in Lund in September next year. This is a satellite meeting to the Scandinavian Society of Anesthesiology and Intensive Care meeting that takes place on September 6 to 8. But in this meeting, we will focus on neuroprognostication, follow-up, quality of life, and rehabilitation. And please, you're all most welcome to join. So concluding remarks. We need to monitor neurological recovery in order to have a careful prognostication. We need strict rules for withdrawal of life-sustaining therapy, and in most cases we need to prolong care. Follow-up of all survivors beyond hospital discharge. We need to assess and put more focus on the needs of close relatives and to offer rehabilitation of those in need. Thank you very much.